Let's take an example. I've done an open traditional L4-5 TILIF in a good surgical setup, taking all the necessary aseptic precautions. On the second post-op day, I see a mild soakage of the dressing. What do? I just mark the area and keep it under observation. However, if there's severe soakage on the day one, I look for the potential reasons. The most common being hematoma formation, which may be check your drain, that it is working well. If the patients are on blood thinners or on aspirin, it's likely to have more soakage. See down retrospectively, see that whether there was initially too much bleeding during surgery or you had inadequate hemostasis, then you're more likely to have more soakage. How do you prevent hematomas? I always use a drain, especially in open spinal surgeries when you have large surgical incisions. In obese patients, because there's going to be a lot of dead space. If they are on blood thinners, diabetics, because hematoma is a good source of infection. We do not want any hematoma there. Hypertensives, because after your hypotensive anesthesia, you have been operating, and once the out of anesthesia, the blood pressure increases, they are more prone for bleeding. Whenever you use implants, especially open surgery, tend to use a drain. When you are suspecting that he's going to bleed a lot, like in scoliosis surgery or in osteopenic patients, I put my drain in passive mode, or if it's charged, I put them on interclamp and release. Always see that you close your surgical site with a tight closure and in layers. Always check if the INR is okay, if the patient has blood thinners, because they may require blood or blood products. Give an injection or tablet pause, compression dressings, icing over that area. However, if there is a signs of increased swelling, pain, neurological deterioration, then they may require surgical drainage of the hematoma. The other reason being serous fluids. When you do not use drain or there is a large hematoma in a dead space, you may see serous fluid. Whenever you use allografts, invariably we see a lot of serous fluid drainage. And in older patients, when there is hypoproteinemia, we do see a lot of serous soakage. So correct the hypoalbuminemia, apply pressure and remove as much of the serous fluid from the surgical site. Give a compression dressing and change the dressing regularly as required. See that your dressing is not soaked in urine and motion, especially when you are operating on the lumbar spine. Change the dressing, see that it is a clean dressing, and continue to use prolonged antibiotics in these cases. Other reason may be CSF, when you notice clear and watery drainage from the incision site, associated with symptoms like headache, nausea, neck stiffness. Evaluate for your neurological symptoms. You can confirm with beta-2 transferrin test, but it's very expensive, takes a lot of time for results to come in, or you can do an imaging like an MRI to detect whether it is a CSF. Management has been discussed by Dr. Badani extensively, so I just skip it. Infection, it's unlikely in the early day or two. However, all fluid which comes out from the wound has to be sent for culture and sensitivity. And if it's infection, we'll discuss later how do you tackle it. So in cases of severe soakage, you note down the vitals, look for the wound appearance, clinical symptoms, document the amount and characteristic of the soakage and associated symptoms and the patient condition, and see that the patient is under appropriate follow-up. Most of the patients are discharged now in the second, third or the fourth post-op day. Once the patient is mobilized, you have checked the dress. Antibiotics, I usually give pre-operative 1 dose of IV antibiotics, followed by, till I remove all your drains, the Foley's, IV catheter, I continue IV antibiotics. Post-op, I do not give any oral antibiotics except in diabetics. All patients on discharge have been instructed regarding wound care, to notify any signs of infection, and when to seek medical help. If there's soakage, if the patient calls up between the 4th and the 9th day, that has some soakage, I call him back to the hospital, check dress. If there's minimal soakage or there's some old soakage and wound shows no sign of inflammation, I will observe. However, if the soakage is there with signs of inflammation, or there is localized collection, I'll open a stitch and allow all the fluid to drain, send it for culture and sensitivity, start them on empirical antibiotics, and convert them to proper antibiotics once your culture comes in. Always do a blood workup like CBC, ESR, CRP, which will work as a baseline for the future. The risk factors for surgical site infections are diabetes, smoking, immunocompromised patients, in open surgeries, or surgeries when there is metastatic tumor surgery, when you're operating for infection itself, fusion surgeries, and in revision cases. If the patient complains of soakage on the 10th day, then I'm worried. You ask the patient for clinical symptoms like fever, which is not very common in the initial post-op days. Pain is the most important symptoms. Pain which is continuous, unremitting, even in rest, not getting better with analgesics. And you should always have high level of suspicion. On local examination, look for localized tenderness, warmth, erythema, edema, and there may be or may not be purulent wound discharge. Do your blood works, imaging, culture. If there's nothing coming from the wound, they may require aspiration. WBC counts, not very a good marker because it's elevated in less than 50% of the cases. ESR and CRP are excellent markers, but not so good in the post-op period because ESR peaks at around 14 and then becomes to normalize takes around 6 weeks. CRP peaks around third day and comes back to normal around 14 days. Procalcitonin, not a good idea at present. SSA, that is serum amyloid A, is an excellent marker in the early post-op period. Not very expensive. Imaging MRI is a modality of choice when you're suspecting infection, and in selected cases, PET-CT. You must ask for culture and sensitivity before starting empirical antibiotics. Blood culture gives a lower yield. Best is from the wound, and if nothing is coming from the wound, you may require to do a CT guided aspiration. This is a new biofire infection panel. Approximately 40 pathogens can be tested, results in an hour, but it's an expensive. It's available, I think, at Bridge Candy at present and has limited availability. Infection is usually during direct inoculation during surgery or around the peri-operative period, or it can be a hematogenous spread. Most of the time it is staph epidermis, especially in case of implants, and gram-negative is usually a hematogenous spread, lumbar spine as it is close to the perineal area, or in patients with long hospital stay. Antibiotics, initially IV and oral, approximately around 6 weeks, keeping a close watch on the markers. You look for surgical intervention in the early cases when the patient is deteriorating or there is a deterioration of the neurological status, or when you want to obtain an intraoperative, you get surgical specimen for culture and sensitivity. Surgical intervention has aggressive and meticulous debridement where all the dead tissue and infected tissue is excised. Wash is given, plenty of saline. You may use dilute povidone iodine or hydrogen peroxide. In cases of implants especially, you may use antibiotic impregnated beads, close over a drain. In cases where there is a lot of dead space or in obese patients or you're not able to close the wound, you may use a WAC and continue use of antibiotics in the right dose. Hyperbaric oxygen can be used as an adjunct for faster recovery. Thank you.